Okay. So it's my pleasure to join Malta in introducing Janet Currie. So welcome, Janet Currie. Thanks everyone for coming. For today's seminar, CCPO is delighted to partner with the Department of Economics and also the Health Economics Seminar run by Debbie Thorne. Fine. By Nat recently, and she's awesome. At the Fielding School of Public Health. So I think this is our first triple seminar across all three departments, and we could be happy to have such a great speaker for it. So we are delighted to welcome Janet Currie, the Henry Putnam Professor of Economics and Public Affairs at Princeton University and the co-director of Princeton Center for Health and Wellbeing. She also co-directs the program on families and children at the MBER. Malta's understanding, who has shared this information with me, is that she's going to move to Yale this stuff.
Yeah.
And so exciting news for me too. Currie is a member of the National Academy of Sciences, the National Academy of Medicine, and of the American Academy of Art and Sciences. And she is now past president of the American Economic Association in 2024. So someone who has done like incredible public goods for our profession. She's a fellow of the American Academy of Political and Social Science and the Society of Labor Economists and of the Econometric Society, and has honorary degrees from the University of Lyon and the University of Zurich. So I'll pass over to Malta for the second half.
Yeah, thanks for sharing that with me. I wanted to say just a couple of other things about Janet too, besides extraordinary scholarship. For as long as I can remember, Janet has been doing really transformative research on child development. And so for many young people in the room, you probably think that working in areas like child development or health or even mental health are very normal things for economists to do. And one of the things I will tell you is that this was not actually mainstream before Janet Currie, who actually has done amazing work to bring that into the mainstream. I mean, Janet was working on things like early childhood and child development way before Jim Heckman got into it. And now everybody's like, oh yeah, this is really great. So Janet has been completely pioneering in that. Another thing
Janet going to win the Nobel Prize?
I guess I'm sure there's an online betting market for this. So her current research really is focusing on socioeconomic differences in health, access to healthcare. You can think about environmental threats on health. In fact, there's so many papers, the important role of mental health, which is going to be the subject of our talk today, and the long run impact of health problems in pregnancy and early childhood. For those of you who don't know, UCLA is particularly proud of Janet Currie because she began her career here in the Department of Economics, and she was also quite involved in the creation of this center many years ago. And so I just say that this to highlight the fact that Janet throughout her career has been an incredible institution builder, and CCPR is one of those institutions that she's contributed to, and as you see, is still here to host incredible work by economists, but also very interdisciplinary and cross-cutting work for scholars of all fields. So thank you very much for your work on that, Janet. I will also say that her excellence in research is really matched by her incredible generosity and spirit as an advisor and mentor. I'm not one of Janet's students, but I have been indirectly and sometimes directly advised by Janet in many points in my career. She has incredible students, many of whom you know. For example, Mike Mueller-Smith was here last week, Janet Currie student, also an institution builder. So there's this intergenerational persistence in many of these public servants. Oh, and it's right there in the second row. It's also here. I'm sure there are many others of us who have been benefited directly or indirectly. So one more. So the other thing I will say is Janet was a very early pioneer of women in economics. There are still not very many of us around, but Janet was around when there were even fewer, and she may have been the only woman in many departments, and her tireless advocacy of women in the profession has led many of, sort of paved the way for many of the rest of us. And it also meant that she won the Carolyn Shaw Bell Award from the Committee on the Status of Women Economics. And that, for those of you who don't know, that's for the advancement of women in the profession. So thank you so much for coming to join us today. I have so many more things I could say, and I think the rest of us do, but that will crowd out your talk, which we very much want to hear. So join me in welcoming Janet Currie.
So thank you so much. It's always a bit embarrassing to sit through one of these introductions. it's really wonderful to be here and to see so many people that I know and miss. And it is kind of a homecoming to come back to UCLA. And I can tell one very short story related to what Martha was saying, which is I have a very clear memory of walking around in the sculpture garden with a very eminent economist who will go unnamed, who asked me what I was working on. And so I started to tell him about my work on children, and he listened for a little while, and then he said, well, that's very nice, but that's not economics. Unfortunately, I decided to ignore him, and the rest is history, as they say. But so today I'm going to talk to you about investing in children to address the youth mental health crisis, which I'm sure you've all heard a lot about. And this crisis has been described by our former Surgeon General, Vivek Murthy, as the defining public health crisis of our time. And if you think about it, that's really remarkable. We just came out of a worldwide pandemic where millions of people in the United States died. And he's saying, no, this is the crisis that we should be worrying about. The American Academy of Pediatrics has also declared a state of national emergency with respect to children's mental health.
And then what age is defined, what age is defined youth?
So I'm going to be focusing mainly on either 10 to 19 or 15 to 19, and that's kind of intentional because I feel like that group is relatively neglected, but I will have some things to say about the whole group, say less than 19. So this youth mental health crisis, you may wonder, like, why is an economist studying this? And I would argue that it's an economic crisis as well as a public health crisis, because mental health problems are very costly, both to the children and families who are affected, but also to society more broadly. Also, I think economists have a lot of tools that are useful for trying to do causal inference and try and figure out what's happening. So this talk is going to have three parts. In the first, I'm going to talk about some of the economic costs of mental health. And I don't want to imply that the economic costs are the only ones that matter. I think like the human suffering is very important, but at the same time, there are very significant economic costs, as I'll show you. Then I want to talk about two things that I'm going to characterize as myths that I think divert attention away from constructive things that we might be able to do on the mental health front. So the first one is the myth that there has been a rapid and really unprecedented deterioration in child mental health. And I'm going to argue that that just is not true. So you'll bear with me and see in a minute what evidence I have on that. The second idea is that trends in youth suicide are driven and move with other mental health measures. And I'm also going to argue that that is not true in the data. And then in the third part of the talk, I'm going to talk a little bit about investments to improve youth mental health and also prevent suicide. So talking about the costs of the youth mental health crisis, one reason why it's very costly is just that there are many people who are affected. So the recent estimates are that about 13% of US children 3 to 17 have a current diagnosed mental or behavioral health condition. And that these mental health services cost $31 billion in 2021. This is from a study using data from the medical expenditure panel study. And again, the reason why it's so expensive is because there's so many children who are affected. There's also other costs like lost parent work time. One study, for example, found that about a third of parents of a child who had a mental health condition were losing 4 or more days of work annually. Now, interestingly, this 13% number is also quite similar to what people have been finding worldwide. So UNICEF for example, estimates that 13% of 10 to 19-year-old youth have any mental health disorder worldwide. So in that sense, the US is not an outlier. It's similar to other places. But where the US is really a big outlier is in terms of suicide rates, both in terms of the trends and also in terms of the levels. So here, what I'm showing you is data from the WHO mortality database for suicide rates for the US on the top and the European Union, 27 country average on the bottom. You can see a couple of different things here. One is that the suicide rates are uniformly higher for males than for females. Secondly, you can see that in the US, you have this sort of U shape, especially for males, where it was going down from a peak in the early 90s and then started going up again. In the EU, it's just been going down. And also the levels are quite different. So in the US, now we have levels of 16 or 17 per 100,000, and in the EU, it's more like 6 per 100,000. Okay, so turning from those short-run costs, you can also think about longer-run costs of the youth mental health crisis. So it's estimated that about half of adult mental health disorders have their start in childhood. And child mental health is more predictive of negative adult outcomes than a lot of common physical health problems. And there's a lot of research now establishing that, but I'll just show you a couple of examples from my own work. This is data from Canada looking at siblings, where one sibling was, I should say the thing about this particular data we were looking at was that everybody is given a mental health screener. So it's not diagnosis, it's scoring highly on a screener that indicates that you have some sort of mental health problem. I have 4 different lines here for different types of mental health problems, but the fact that all these lines are sloping downwards means that as a child has worse mental health, their outcome relative to their own sibling is getting worse. So the outcome that I'm looking at here is whether they are still in school at age 16 to 19. Okay, so compared to your own sibling, if you have a mental health condition, you're less likely to persist in school. And then another example, here the lines are going to slope up because this is looking at the effect of having a mental health condition at various ages on receiving social assistance after age 18. And so again, this is using Canadian administrative data. Here, I'm looking at diagnoses, not a screener. But the striking thing is how much more predictive of being on social assistance having ADHD or conduct disorders is compared to having asthma or having some sort of what's characterized as a serious injury. Some other data along this line. Yep, Natalie?
Just to fix ideas a bit, when we talk about 13% of youth having mental health issues, like what is kind of in that bucket of mental health? Is a lot of it some specific set of issues? Is a whole constellation of issues? Like, there was a lot of ADHD, or is it depression? What's kind of
so, a lot of ADHD, a lot of depression, a lot of anxiety. Anxiety disorders are huge. I would say those are kind of the major categories.
Do you have any idea if any of this is caused by ACEs, adverse childhood experiences, where we've learned that if you intervene early, you can save the impacts later on?
So that's a good question, and I'm not going to talk that much about the causes. I will, partly because what I want to focus on is the trends.
Oh, yeah.
And I don't think that something like ACEs could explain a huge increase in mental health. I mean, I think one of the puzzles here, as I'll talk more later, is that in general, a lot of things have got better for children. So then why should mental health be getting so much worse? Okay, so Here, what I'm showing is data from the UK, looking at working days lost. And the striking thing here is that if you put things in big buckets, mental health, musculoskeletal conditions, and then everything else, what you see is that mental health really dominates in terms of predicting working days lost. And if you look at, for the US, data from the Social Security Administration on disability, you also see that mental health conditions are a really big cause of disability. Okay, so these are just really big costs if you think about all these people being taken out of the labor force because of mental health conditions. Okay. Some additional costs, although here, we don't really know what's a cause and what's an effect, but I think it's worth noting that 2/3 of unhoused adults have mental health disorders. This particular paper is a meta-analysis using studies from the US, Germany, and the UK, and finding pretty high rates among homeless people in all of those places. And then something that's more peculiar to the US is that we have such a high fraction of people in jails or in prisons who have a mental health condition, such that our prisons are the leading treatment site for mental health in the whole country. Okay, so these are things that we can also view as additional costs of mental illness. And so what this suggests is that this is really a very costly thing that we should be paying attention to. Okay, so turning to the second part of my talk, talking about myths about youth mental health. The first thing that I want to address is this idea that this is just completely unprecedented, what's happening. Okay? And even the word crisis suggests that it's something that hasn't happened before. This is really important to nail down, because if this is something that's recent, then the cause must be something that's recent. And I think this is like the number one reason why everybody's pointing at social media, right? Because they're trying to look for something that didn't exist before. If the crisis didn't exist before, then maybe it is caused by this new thing on the block, social media. So here's sort of exhibit one. This is a report to the US Congress from 1970 that was entitled Crisis in Child Mental Health. So it's exactly the same language. And this particular report found that 10 to 12% of US children had a major psychological problem in the early, late 60s, early 70s. So that's actually very similar to the estimate that I gave you of 13%, except that was for any mental health problem. Right? And at the time that this report was written, it was believed widely, for example, that children could not be depressed because they were not psychologically advanced enough to be depressed. And so, when they say major psychological conditions, I think they really mean that. Right? So if you take these numbers at face value, it suggests that things might even have gotten better today relative to what they were in the 70s. A similar sort of thing is a report from 2000. So again, 25 years ago, the Surgeon General calling for national action to address the state of children's mental health. The Surgeon General convened a conference, they issued this report, and at that time they estimated that 11% of children were suffering from a significant impairment from a mental health disorder. And so the evidence that's out there suggests that this is something that has periodically kind of risen to the surface of public discussion, but that may be actually relatively constant over time. Okay, so if these rates are actually constant or even falling, then why do we have so much discussion about, especially increases in certain diagnoses? And so I'm going to talk at some length right now about like arcane things, changes in measurement, but also looking at this from an economist perspective, changes in incentives for both patients and doctors to provide a mental health diagnosis. Okay, so thinking about changes in measurement, a really important thing to keep in mind is that in 2013, there was a change in the Diagnostic and Statistical Manual of Mental Disorders. This was like a complete revision, and this particular guide has been described as a Bible for clinicians in terms of describing what are the symptoms of mental health disorders. So some of the things that were changed, and these are just a few examples, are that there were additional conditions that were added to definitions of depression and anxiety. So a significant one, for instance, you hear a lot these days about people with PTSD for one thing or another. PTSD used to be in its own category. Now it's in the anxiety category. Okay, so if you look at anxiety, you'd expect that that one change would increase the number of people with an anxiety disorder because now this other thing has been moved there. Similarly, for depression, there were things like dysthymic disorder, which is sort of low-level persistent depression, which were added to the definition of major depression. So you have a lot of changes in definition that make it hard to look at time series. Another really interesting one, at a certain point, there was a lot of discussion of an explosion in diagnoses of autism and a lot of discussion about what this was due to, whether it was some sort of environmental pollution or something. But overlooked in that discussion was the fact that the 2013 change combined 4 different disorders into one new autism spectrum disorder. So again, just mechanically, if you had autism by itself and then these 3 other things, and then you bunch them all together, you get an increase. And then a third example is with ADHD. And there the definition changed. It used to be, before the DSM-5, that you had to have shown symptoms before age 7 in order to qualify for an ADHD diagnosis. They changed the threshold to age 12. So what that means is that there's a whole bunch of people where their symptoms might have first been noticed sometime between age 7 and age 12, who are now eligible to get a diagnosis of ADHD. Okay, so there's a lot of these changes, and that's important. There are also changes in incentives. So if you think about it from a patient point of view, what's the point of getting a mental health diagnosis? Well, I could get treated, which is important. For children, I could qualify to get an individualized education plan. I could also qualify to be on disability. So there's a bunch of incentives. There's also costs. So one is that it may be very costly for me to get medical care. Another is that there's huge stigma still associated with mental health diagnoses. But there's evidence that the stigma associated with mental health has been falling over time. This paper by Pescondolito is very interesting. She's using data from the General Social Survey, where they ask people a couple of questions about stigma. So one was whether they would try and avoid people who had mental health conditions. And another was whether they believed that there was a biological basis for a mental health condition. So the answer to those 2 questions is more people are saying, no, I wouldn't shun somebody just because they had a mental health condition. And yes, I believe that there's a biological basis. So it's not just like a moral failing or something like that. So these things would, if you read, and then I should say the expansions of health insurance, such as mental health parity laws in the Affordable Care Act and before that, have also reduced the cost by expanding the insurance coverage of mental health conditions. So the patient cost relative to the benefit may be falling over time. And then looking at the provider side, there's quite a bit of evidence that providers are very responsive to incentives in terms of how they diagnose things. So just as an example of that, in a study with Anna Cherney using data from South Carolina Medicaid, we looked at the switch from fee-for-service plans to capitated plans. And an interesting thing that we were able to do was actually look at the contracts. So we could see that these contracts had a couple of interesting features. One was that they paid a higher capitated fee if a child had a chronic condition, right? So in a managed care plan, what happens is the provider gets one fee and then they're supposed to, that's supposed to cover all the care, okay? So basically you would get a higher fee if you said that the child had condition X. And then the other thing was that they would penalize doctors who were below average in well-child screenings. Well-child screenings include screenings for mental health conditions. Okay, so there were sort of carrots and sticks here that would tend to increase the number of screenings and also increase the number of diagnoses. So what we saw was following the same child over time. So these are all kids, they're all on Medicaid, so they all have the same nominally, same type of insurance. Following after, before and after their doctors are switched to these new plans, we see this big increase in the number of diagnoses of chronic conditions. So the two orange bars here are showing two of the most common mental health conditions, ADHD and depression. But, lest people think that, oh, they're just cynically labeling kids with mental health conditions, we also see increases in diagnoses of things like asthma, ear, nose, and throat, autoimmune conditions, and even mild infections. Okay, so basically, we incentivize doctors to screen more, they do more screening, they find more things. So to dig more into these effects on provider incentives, we use data from the Nationwide Emergency Department Sample, or NEDS, to try and see these effects. And the reason why it's interesting to look at emergency departments in particular is because emergency departments are kind of the first line for getting care for mental health conditions. If you telephone a mental health provider after hours, you will get a recorded message that says, if you're having a crisis, go to your nearest emergency room. So you see people appearing there. The NEDS is a 20% sample of hospital ED claims representing 39 states and the District of Columbia. So it's about 30 million ED visits per year. And it has some basic demographics. One limitation is that in the NEDS, I don't know the state. I only know 4 census regions, which is sort of unfortunate because California gets lumped with the West, even though it's, as I'll show you in a minute, it's really very different in many ways. Okay, so looking at the NEDS, what I want you to focus on here first is the blue line. So this is the number of ED visits for people 10 to 19 with any mental health disorder. And it's been normalized, so the first year of the data is 1, just so you can see the trends more clearly. Okay, so the blue line shows that there's increases in ED visits for mental health conditions up to about 2018, and then it starts to fall. Okay, but the other 2 lines, what I've done is just separate ED visits for any mental health condition into 2 buckets. So one bucket is mood or anxiety, that's the red dots. And the other bucket is everything else, that's the black line. Okay, so what you see is that these things all track pretty well up until 2011. And then there's a clear bifurcation where you have a big rise in mood and anxiety disorders and a big fall. Well, not a big fall, but at least a leveling off and then a fall in everything else. Okay, so clearly there's something really different going on with mood and anxiety disorders than with other mental health conditions. And that's really driving this increase in visits to the ED. So again, I want to come back to this idea of provider incentives. So what could be driving this huge increase? one important thing I'll argue is that in 2011, the US Preventive Services Task Force recommended screening women and girls annually for depression. So this is, I'm not thinking here about screening people in the ED. I'm thinking about screening people in their regular well child appointment, and then determining that maybe they're depressed, and then they have a label saying, okay, I have depression, right? Then in 2012, the ACA mandated that the insurers pay for any care that was recommended by the task force, so that we had, because not all recommendations get followed, right? Just because the task force recommends something doesn't mean that all the providers do it. But in this case, there was a recommendation and there was a mechanism for getting paid for implementing that recommendation. So I think the take-up was greater. Continuing with this idea about incentives, so that's an incentive to screen. There's also an incentive to code secondary mental health diagnoses in order to get higher reimbursements. And the idea here is just that if you have somebody who has a complex case, it's fair to get reimbursed more than if there's a simple case, right? So if I have a disorder like asthma, but I also have a mental health disorder, I may be more difficult to treat than somebody who only has asthma. Okay, so in 2007, there was a change in the Medicare diagnoses that increased payments for cases that had secondary diagnosis of mental illness. Okay, so Medicare is for elderly people. It wouldn't necessarily be expected to have an impact on children, except that you can't really train clinicians to code like one group of people one way and then code everybody else some other way. So there's evidence that this spilled over to other patients and, changed, basically caused clinicians to code more secondary mental health diagnoses. Then in 2015, there was another change in the way that things get coded. This one having to do with the International Classification of Disease, which is what's used when you go to the ED or the hospital to say what's wrong with you. Okay, so in 2016, the revision encouraged clinicians to code suicidal ideation as a secondary diagnosis if it was present. So if we look at the coding of suicidal ideation, what we see is this. The red line is for females and the blue line is for males. And so you can see that from 2006 to 2011, there's an increase in coding of suicidal ideation. But in 2011, the lines start to diverge and you get a higher increase for females than for males. And then after 2016, you get increases for both females and for males in diagnosis of suicidal ideation. This is a very sharp increase. It's about 40% increase in diagnosis of suicidal ideation within 1 year after the change in this coding convention. Okay, so this may make you wonder, well, maybe it's not so great to look at ED visits. Is there some other data that you could look at which would be more constant over time? And it turns out that a lot of surveys that have questions about mental health have not asked the same question in the same way over time. But an exception to that is the youth risk behavioral surveillance surveys that have been conducted by the CDC every 2 years since 1999. And in fact, the 2025 wave should have been in the field, and I don't know what's happening to it. But anyway, this is the largest source of health surveillance data about high schoolers in the US. It's conducted anonymously in schools, usually in the spring. And a nice thing about it is it has state level data available for most states. Although a drawback is that there's little demographic information or little information about the families. So the questions that they've been asking about teen mental health and suicidal behaviors are, first, during the past 12 months, Did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that you stopped doing your usual activities? Okay, so you may have read in the newspaper articles about hopelessness among young people and big increases in hopelessness among young people during the pandemic. This is what they were talking about. This is the question that they were using. Then they asked, during the past 12 months, did you ever seriously consider attempting suicide? And they also ask a question about making a plan. And then they ask, during the past 12 months, how many times did you actually attempt suicide? So if you look at trends in these measures over time, I think you see some very striking things. The first thing that's really striking to me is just that even if you go back as far in time as you can, you see very high fractions of youth answering yes to these questions. Okay, so if you look at the top line here, which is for females, what fraction of them were feeling sad or hopeless? They start asking it in 1999, and you have 35% of people endorsing that. Okay, so you do see an increase after 2009, peaking in during the pandemic, and then starting to come down. For boys, the rates are lower, so we have about 20% of them saying that they felt sad or hopeless for 2 weeks or more, and then that's remarkably flat up until about 2018, then it goes up. And then looking at the other two measures, whether somebody says that they considered suicide, again, it's pretty shockingly high. So in 1991, when they first asked the question, they had almost 40% of girls saying that they had considered suicide, and then that falls until 2009 and then starts to go up again. And again, looks like it might be leveling off. And then the last two lines here, looking at people who say that they attempted suicide, again, these are really shockingly high numbers, relatively flat over time. And one thing you can do with these numbers is you can try and validate them by comparing them to some other source of data. And on the attempted suicide, you could compare them to the CDC's injury surveillance data, WSICRS, and these numbers are about 17 times higher than the number of people who have an injury requiring medical attention resulting from self-harm. So I think that means either that a lot of teenagers, it could be some teenagers themselves have told me that like they wouldn't take this kind of survey very seriously and they would just make things up. So that's a possibility. Another possibility is that there are a lot of people who consider that they attempted suicide even though there was no injury that resulted in requiring medical attention. Okay, but my overall takeaway from this is that there have been for a long time very large numbers of children expressing mental distress. And that, it does seem to have increased recently, especially for girls. But again, that this is not like a new crisis.
Janet, do you have comparable data for adults? I mean, is this much higher or about the same or what for adults?
Actually, you do have somewhat comparable data from BRFIS, the behavioral risk factors surveillance survey. And these numbers are not that different than for adults. But if you look at rates of depression for teens, they're not that different than for adults.
Wow.
Yeah, you have a lot of people who have mental health conditions, right? That's part of my part of my overall theme here. Yeah.
I think the figure you showed us earlier showed higher suicide rates for men. Do you have an idea on why those are different here?
Okay, so that will lead right into my next point, right? So that's very good that you observed that, because my next point was going to be that suicide and mental health measures don't track very well. Okay, so one obvious way that you can see that is just that women always have worse mental health, but they have way lower suicide rates. Okay. So this is myth number 2. The reason why I think it's important to address this is that if these things are not moving together, then that suggests that there are other factors that are moving suicide, and maybe we should figure out what those factors are and address them if we want to actually do something about suicide rates. Okay, so the data on suicide here is going to come from CDC. You can apply to get data that has county level identifiers and does not have suppressed counts. The public use data has suppressed counts, especially for girls, because suicide is still a rare event. Okay, so looking at how different measures track, the orange line here is looking at the suicide death rate for 10 to 19-year-olds. And then I'm also looking at ED visits with a mental health code for 10 to 19. And so, you can see that they both generally increase over the period, but they don't track each other particularly well. For example, in the early part of the period, you have total suicides being flat while ED visits are increasing. And then they actually cross around 2016. So ED visits, start coming down earlier than suicides. Looking again at the Youth Risk Behavioral Surveillance Survey, here I've pooled the boys and girls, but thinking again about what the suicide rate looks like, we have this big increase in suicide. We don't have a big increase in hopelessness except at the end of the period. And then looking at suicidal ideation, which you might think would be the most directly related to suicide, they don't track at all. And this is, I think, because of these changes in coding. So here the red dots are the suicidal ideation line that I showed you earlier. The orange is still the suicide rate. And the green dash here is ED visits for self-harm or suicide attempts. So that tracks better. So if you had to pick a measure that might track suicides, it would be this self-harm or attempts measure. But another way that you can try and look at suicides is by looking at the geographical variation. And so one of the things that I think is not very well understood about US suicide rates is how huge the geographic variation is. This is deaths per 100,000 people. And you can see in the Northeast and in California, the rates are fairly low. And in fact, they're comparable to the rates I was showing you earlier in European countries. And then if you look at the sort of Mountain West, you see these extremely high rates, more than 7 times higher in some of these states. Okay? So, clearly there's something that's very different happening in these two places. To get some idea about what that might be, you can also break down suicides by means. And so here, for the 4 regions that I have in the NEDs, I'm breaking down suicides. The overall line is the purple line. And then the main means are broken out by the other lines. So the green dots here is deaths by suffocation. The blue dot dash is deaths by firearms. The orange is poisoning, so that's the drug overdoses. And I broke that out specifically because when people think about suicide, they think about drug overdoses. Many suicide attempts are drug overdoses, but few relatively successful suicides, I shouldn't use successful, completed suicides are from drug overdoses. And then the turquoise line is everything else. Okay, so you can see that the main causes are either firearms or suffocation. And the places that have really low suicide rates have low suicide rates primarily because they have low deaths from firearms. Okay, so trying to look into that a little bit more systematically, we used data from Michael Siegel's state firearm law database. And there are many, many different kinds of firearm laws. So to try and classify them, we used Everytown for Gun Safety's classification. And they classify laws into what they call foundational gun safety laws. And then I'm going to show you two different things. One is just a regression where we look at the number of laws conditional on the fraction of youth who say that they're hopeless, and condition on state and year. So we're looking at the effect of changes in the number of laws. And we look at deaths by, total suicides, firearm suicides, suffocation, and also the difference between them. And the reason why we look at the difference between them is because sometimes people will say to you, oh, if you prevent people from killing themselves using a gun, they'll just find some other way, right? So the question is there actually substitution or not? Okay. The foundational laws that we use can be grouped into these categories. One is, was there a background check or a purchase permit? Second, do they have some kind of law that allows law enforcement to take guns away from people who might be a danger to themselves or others? 3, is there a law that's intended to prevent children from accessing firearms? 4, do you require a permit to have a concealed weapon? And number 5, whether you have not passed a shoot first law. So a shoot first law, basically under common law, without such a law, you would have a duty to deal with the situation by non-lethal means if you can, like run away. But if you have a shoot first law, you can shoot first. So, okay, so looking at the effect of those laws, an additional gun safety law is associated with about a 6% decline in suicides. This is for all teens 10 to 19. You can see most of that is coming from reductions in deaths from firearms. Very little change in deaths by suffocation, and certainly no increase. And the difference between firearm and suffocation deaths is also significant. You can also see that the percent hopeless matters too, but even conditional on that, the gun safety environment matters. We can also do this just for males, 15 to 19, because they're the group that have the highest suicide rates. And you can see that the pattern is even clearer, although the baseline is much higher. So the percent change is not actually that different than in the previous regression. We can also do some event studies looking at changes in laws. And for this, we want to have a period before and after the index law change where there was no change. And so it turns out that most of the laws that fit that criteria are in these last two categories. There were a lot of states that passed a shoot first law, and there were a lot of states that repealed their concealed carry permit laws over this period. So I'm going to call those gun freedom laws. And what you see is that the passage of a gun freedom law is associated with an increase in firearm suicides and no change in deaths by suffocation. Okay, so returning to this issue about social media, one might ask, well, why didn't you do the same regression for social media? And the reason is you can't.
Sorry, I'm happy if you want to move on, but I had a question on the gun piece. So have you taken that back and adjusted the US suicide rate based on, is it mainly gun violence? Would if you take away adjust the state's mortality rates using these regressions
a
and
big
compare
part of
them?
it, a big part of it is, but it was actually less than what I expected. So when I started doing this, I can honestly say I expected that it would explain everything. I don't think it does explain everything. And there are some European countries that have a lot of guns around, right? And don't seem to have the same problem with suicide. So I could not honestly say that it was entirely firearms, but it does seem to have an impact.
it would be interesting to see the interaction effect with hopelessness of the fire law. Right? Presumably, that might be a bigger effect.
Just one quick question on the laws too, that obviously not all laws are alike, and that this group is 10 to 19. I'd assume a lot of them, it's the concealed carry issue might be less relevant than whether they can access the gun in the home or what the screening laws getting them access to the guns. Did you look at that one separately? I mean, the others affect young people through kind of maybe prevalence of guns in their communities as well. But then the access and the laws preventing their access to the guns seems especially important for young people. Did you look at that one on its own?
So we've done a lot of different permutations of this, and it does tend to be true, as you say, that you know, some laws are more important than other laws, but we were trying to be very like hands above the table here and just use somebody else's classification and show what happened. Okay, so going back to social media, we know that you know, there's some very nice randomized trials doing things like paying people not to look at their cell phones, and those do have effects on people's self-reported mental health. I will say those effects are small. The questions about social media have not been asked very consistently over time, which isn't very surprising if you think about it, because social media has been evolving so much over time. It's not even clear you could ask the same questions over time. So what I will just show you is that in a cross-section, if you use data from the Youth Risk Behavioral Surveillance Survey on the amount of time that people are spending on screens, it's actually negatively correlated across states with the suicide rate. Okay, so in this figure, the three outliers there are the states that had the very high suicide rates. You know, so it's not the case that Montana has a very high suicide rate because everybody in Montana is on social media all the time, right? It's the reverse. So people in New York, New Jersey, California, who have the low suicide rates, who are on social media all the time.
So have you considered doing this graph after residualizing from the gun effect?
Oh, take out the gun laws? I could try doing that. I haven't done that. So this is just showing you cross-sectionally what's in the data. Right. So it's like trying to imply that, you know, social media can't really be the whole story, but many things that I've said suggest that, right? Is if we had 30% of youth who were hopeless in 1999, it wasn't because they were scrolling their phone all the time. Okay, so part 3, thinking about investments to improve child mental health and reduce suicide. You know, I think this is important because if people don't know about the effectiveness of investing in children, then that tends to undermine support for public investments, as we're seeing. And the US has, over the past 20 years, greatly increased investment in children. So it's hard to put all the different kinds of investments together. Here we're trying to include state and local and federal. But overall, we estimate that there's about a 60% increase in investment over this period. And by the end of that period, that brings the US up almost to the same level as some comparison countries like the UK, Sweden, and Germany. So the US is still lagging behind as of 2019, but a big improvement. And at the same time, you do see improvements in a lot of different metrics of child health and well-being. And so I've been focusing on suicide. That is a small part of child mortality. Overall, child mortality is going down dramatically in every age category. The fraction of young adults who have at least high school has increased. The teen birth rate has collapsed. The arrest rate for violent crime for 0 to 17-year-olds is less than half of what it was in 1990. So in many ways, what I've been talking about, the mental health crisis of suicide, is a real outlier in a puzzle compared to all this other kind of good news. Okay, so that makes you wonder, you know, is there potential for these type of investments to affect this particular set of outcomes? And I would argue that there is some evidence for particular types of investments. One is prenatal support through the WIC program. So in work with Anna Chorney, we looked at children whose mothers participated in WIC during pregnancy compared to their own siblings, where the siblings didn't participate. We can follow the children using South Carolina Medicaid records up to age 6 to 11. And we just look at what's the probability that they're diagnosed with a mental health condition at age 6 to 11. So there we're focusing on mental health conditions, which are typically diagnosed at that age, which doesn't include things like depression, which is mostly a little older. And what we see is a reduction in the probability that a child is diagnosed with ADHD and also other mental health conditions that are typically diagnosed at young ages. And we also see that the effects are larger for Black children than for other children, where the Black children's mothers may have faced more difficult circumstances during the pregnancy. There's also evidence that early childhood programs can improve child mental health, and that might be one of the ways that they improve outcomes more generally. So for example, in Jim Heckman's work, looking at the Perry preschool experiment, he shows that it reduced externalizing behaviors. So those are things like ADHD and conduct disorders that I was showing you earlier were related to future outcomes like being on welfare or having limited educational attainment. The data on suicides, this is looking at it yet again a different way. If you look at the trends over the school year, it really suggests that interventions in schools might be one way to address it. So what is this showing? It's showing that there's, for 15 to 19-year-olds, a peak around March or April, and then another peak around October, and a big dip in the summer vacation period, and also the December vacation period. I've drawn two different lines here. One is for 99 to 2004, and the other is 2014 to 2019. And you can see that, if anything, those peaks have sort of gotten more pronounced over time. And then you can also compare the 15 to 19-year-olds with the 20 to 24-year-olds, and you see, much less of a peak in the older group that are out of school. Okay? So another piece of evidence that suggests that there may be something wrong in schools is that youth suicide actually fell 25% with the March 2020 school closures, and then increased as the schools gradually reopened. One possible mechanism for this is the role of bullying. And you may recall that when schools went online, everybody was very worried about cyberbullying. Cyberbullying actually went down because it turns out that in-person bullying and cyberbullying are actually complements and not substitutes. So most of the time, the cyberbullying is referring to something that happened in the school. So when you shut the school, you had less of both. Another possible mechanism is just pressure. And so here I've been doing some work looking at data from Taiwan, where they have very strict school entry requirements. So if you're too young to enter school, you have to wait for an additional year. So here we're comparing, well, that allows us to look at what happens when kids enter school in terms of whether they get treated for depression. So we see an increase at a primary school entry. That could possibly be because kids are being monitored more once they go to school and not because their mental health is deteriorating. But if you look at middle school entry, kids are already in school, they're already being monitored. But then when they go to middle school, you get this big increase in use of antidepressants. And then another feature of the Taiwan school system is high stakes tests. So there's a high stakes test to get into high school. There's a high stakes test to get into college. And after the kids write those tests, then you see the use of antidepressants falls off. Okay, so this is suggestive that just the pressure in the school system could also be one of the things that affects mental health. So there's some evidence that school-based services can help. There's a very nice study by Ezra Goldberstein and his co-authors looking at the rollout of licensed clinical mental health workers in Minneapolis schools. He has administrative data, he has a student survey, and what he shows is that having in-school mental health services increased utilization of mental health care, improved discipline as measured by disciplinary infractions, and reduced self-reported suicide attempts. There wasn't actually any effect on test scores, but maybe that could be interpreted to mean that they're not like taking away from learning resources in order to provide these other resources. There are a lot of other promising investments in adolescence that I won't have a lot of time to go into. So I want to spend my last couple of minutes talking about the possibility of improving mental health by providing better treatment. So, what does treatment look like? The first thing to realize about it is that there's huge geographic variation in child mental health treatment in the US. So what this map is showing is data on antidepressant prescriptions per capita for 10 to 19-year-old youth. You can see that it varies from almost nothing to a very high rate of like 1 30-day prescription per year per person almost. Okay. So there's a lot of variation. There's also a lot of very concerning prescribing behavior going on. What we did in this study was look at the children in claims data for a large private health insurer. So they all have good health insurance. And then say, what happens the first time that they get treated for a mental health condition? And what we see is that the first time that they get treated for mental health conditions, so think of a 12-year-old who's depressed, 15% of them are getting benzodiazepines, 13% of them are getting a drug that's not approved for any use at all in children. A bunch of them are getting tricyclic antidepressants, which are older generation antidepressants that are not recommended for use in children. And then 13% of them are actually getting more than one prescription. So we estimated that only a little over half of the prescribing met kind of minimal guidelines. We also see that this is related to the type of medical personnel that you have in your county, not necessarily in the way that you would expect. So if you hold everything else about the county constant and increase the number of child psychiatrists, you actually get more of this type of prescribing and not less. And you can also do the reverse and say, well, what happens if we hold everything constant and just have more therapists in this place? Then you tend to get more therapy and less of this concerning prescribing. So in some additional work with Emily Cuddy, we show that this kind of prescribing is actually harmful. We used these variations in provider supply as an instrumental variable for the type of treatment that children got. And then we followed kids for 3 months, 12 months, 24 months after an initial episode. And what we see, if you think about it kind of like this tree, is that if you got drugs when you were treated, it actually reduces the probability that you have self-harm after 24 months. But it matters very much what type of drug that you got. And so here there's 3 buckets. One is whether you got one of these red flagged prescriptions that I was talking about. On the other side, you have whether you got something that was FDA approved. And then there's this sort of what we call just a gray area where there might be some indication in the literature that this is helpful, but it's not FDA approved. And you can see that there's like a monotonic pattern there in the probability that the child has been treated for self-harm after 2 years. Okay, so I think I should end. So I'm going to skip that and just conclude. So I hope I've convinced you, but if you didn't think so already, that the mental health crisis is very costly and is something that really merits our attention. Also, that it's existed for decades, so it is not new. We shouldn't think of it as new. Perhaps all the current discussion will actually, result in some action being taken, unlike what's been happening for the last 50 years. Also, suicide rates vary conditional on other mental health measures. And so there are things that could address them, such as gun safety laws, even if underlying mental health stayed the same. And finally, investments in children have the potential to reduce suicide, improve mental health, and reduce this economic and public health toll. So thank you. Okay, good.
Yeah, you kind of thrown out a lot of ideas about policy here, right? Gun control, switching to therapy versus, different prescription drugs. Like, what do you think is going to work the best of all these, in terms of costs and benefits?
Well, there's what you think would work the best, and there's also things what might be doable. I do think that on the treatment side, more attention to what doctors are doing and also informing parents about like what is appropriate care could be beneficial. One thing I'm very curious about is in the UK, you have the NICE, right, who puts out these guidelines. And they have two kinds of guidelines. One is for clinicians. So if I'm a family doctor and I don't really know how to treat depression in kids, I can go online and I can find something that's in medical terms. But if I'm a parent, I can go online and find something that's in layperson's terms. And it says, well, on your first visit, this is what should happen. And then, if you try this and it doesn't work, here's the next thing that should happen. And it's really nicely and clearly laid out. So what I wonder is if people had more information of that kind, would that reduce the amount of really bad treatment that's happening and improve outcomes? Yeah.
Yeah, John, I'm going to follow up on that and ask you to go back to the slide you skipped. Because we've got issues of geographic disparities in psychiatrists. We've got geographic disparities in clinical psychologists and social workers. So the question is whether drugs or substitutes, bad prescribing of drugs as a result of more people going to primary care and not getting the specialty care, whether more use of drugs is associated with lower availability of talk therapy or other kinds of non-drug therapies in the region. So I'm just wondering, how far has the research gone in sort of sorting out why the treatment patterns are what they are based upon the local healthcare system that's available to the kids with these mental health problems?
Okay, so I've actually been trying to do a lot of work on that. I don't know with what success so far, but one thing I can say for sure is that on average, like child psychiatrists are better than the primary care physicians, but there's a lot of really bad prescribing by child psychiatrists. And some like one intriguing thing, for example, is that I guess it's well known that in the US that kids on Medicaid are more likely to get more than one prescription. And in particular, they're likely to be treated with antipsychotics, which is really not very appropriate, but the antipsychotics are kind of sedating. So basically you have a disruptive kid, you can't think of what to do with them. And so you prescribe them antipsychotics. What we showed using Canadian data, where all the kids have health insurance, was even kids would go to the same doctor, and the low-income kids were more likely to get antipsychotics. Okay, so it's not that the doctor doesn't know any better. presumably, or maybe they would be treating everybody the same. But there must be some other reason why they're doing that. And so what you're saying is like, well, maybe there's no therapy available, maybe there's no other thing that I could do except medicate this child. But putting them on antipsychotics is pretty terrible, right? Because there's all these metabolic side effects and but there's a lot of that happening.
Can I ask a follow-up on this? Like, I've heard somewhere about like a litigation risk being a possible reason why doctors may be doing that. Like if the kid ends up dying by suicide, they can show that they tried to do something if they prescribe like a harsh treatment. Do you think that could be?
So I think psychiatrists actually face little risk, because if somebody's mentally ill and suicidal anyway, it's going to be hard to prove that anything that the doctor did caused the bad outcome. So I actually think the tort system is probably not very effective in regulating doctor behavior. And plus, that the standard is usually, well, is what the doctor did reasonable by some standard? And if you can point to a whole bunch of other people who are prescribing in the same way, even if it's not something FDA approved, I don't think, it would just be very difficult to obtain any conviction or, yeah.
Do you think this also applies to adults, or is there something special about children? Like, is there also a lot of variation in the quality of mental health treatment in adults?
Oh, yeah, there's huge variation in that too. So I have a paper with Bentley McLeod looking at antidepressant treatment among adults. And there what we show is that so the delicate thing is that you don't want to replace doctors with robots necessarily, right? Because presumably they know something. And so if you have a good doctor, you would like the good doctor to be able to do their thing, right? But what you would like to do, I would argue, is get rid of the tails of really bad prescribing. So we estimate a model and we say, well, how much better would outcomes be if you just got rid of this like really bad prescribing behavior? And they would be a lot better.
It's not that children are super hard to treat. This is just kind of a broad.
Well, I think children are more difficult to treat. The other thing that's different about adults is that, say, if I'm 40 years old and depressed, chances are I've been depressed before. I might have some idea about what works for me, what doesn't work for me. And also, if the medication makes me feel awful, I could stop taking it, right? Whereas with a child, they may have less agency. Yeah.
So on that note, I was also wondering, are there any sources of data where you can look at households or families? Because obviously parents are working with professionals in terms of seeking mental health treatment for their children. Parents may or may not have experience themselves with mental health and mental health treatment. And I would imagine that has some big regional components as well, following up on Natalie's question.
Yeah, so that's another thing that I've been trying to do, actually. So you could do that using claims data to some extent, because you have the person who's covered and then you have their dependents. One of the problems is that often in claims data, you don't see both parents because you only see the one that's covered. So it's kind of imperfect, but that is one option.
I've been thinking about work by one of your former students that is about how school shootings can have spillover, like negative effects on the mental health of kids after the event. And I was wondering if you have thoughts on like the role, like how big is this in the series that you've been showing about the trends in mental health? Like,
yeah, I actually was looking at that because you can get data on school shootings and just wondering to what extent that might be driving things. I guess trying to remember what I found. I guess what I remember about it is being appalled by the large number of shootings, even going further back. That there have been periods of time where there were large numbers of shootings. So it wasn't what I expected to see, that it was really much more recent. Yeah.
You've done some work in the past on how physical health evolves over the age of the kids into adulthood. And I was wondering, I was thinking about prevention, right, related to your WIC study. You know, how much of these mental health issues arise in early childhood or even in the womb, right? And what's sort of the pattern of development, and where would we ideally intervene if we wanted to intervene early? What do we know about this profile?
Yeah, what I suspect is that, like a lot of other things in child development, there's kind of two periods where it's really important and a lot of things are happening. One of them is early childhood. And so you do see kids that sort of get off on the wrong foot, and then it's hard for them to recover. But then you also see people who seem like they're perfectly fine and then go off the rails as teenagers, right? So that's another period of time when kids are really at risk in some sense. And it's also a time when a lot of mental health conditions sort of first manifest, right? So you have the kids like with ADHD and conduct disorders and maybe Asperger's at young age. And then as those kids age, they're more subject to get depression, anxiety, and then other kids are sort of coming into the pool with depression, anxiety, and then like people in their late teens and 20s might end up with psychotic disorders and things like that. So there is this sort of trajectory.
I think my question was, how much of those incidences are predictable, say, by all the shocks or predispositions kids are exposed to, right? From parental, depression or mental health issues to income to school shootings, right? You could imagine having sort of a predictive model trying to flag kids for early intervention at both stages of use of one.
Yeah. So there was a study in Montreal by Tremblay looking at a cohort of children and following them over time and looking at the effective intervention. And I guess one of the takeaways from that is if you have behavioral measures on the kids, you could predict with some reliability who was likely to end up with mental health problems later on. And you could target people for intervention. Yeah.
So just moving from the substance to methods and data. You commented that changes in the coding, what goes into the diagnoses, and changes in the incentives to get the diagnoses down both influence the data. And you showed big changes in trends associated with changes in coding and changes in incentives. So were the old measures wrong? Are the new measures better? Are the old measures underestimating what the activities and mental health status of children? And are the new versions of these measures overestimating or getting it right? You've worked with this data for a long time. How's the change? Are you happy with the changes in the measurement, or do you think that it's still getting it wrong?
So what I observe over time is a lot of relabeling. So, you have a child that obviously has a problem, and then over time it gets labeled differently. I guess what the psychiatrists working on the DSM are interested in is the reliability of their measure. Like if you took 20 psychiatrists and they all diagnosed the same kid, to what extent would they all come up with the same label? But I guess the way I feel about it is that 20 years from now, we may be looking back at some of these labels and thinking like, oh, those are, like we think about Victorians, there used to be in death data, people used to die of things like the dropsy. what does that mean? That just means you have swelling, right? So there's lots of things that could cause dropsy, but that's what people would put on cause of death. So with mental health, we don't have absolute measures of any of these things. We're just trying to measure from the symptoms what somebody has. And even over a short period of time, you can see diagnoses go sort of in and out of fashion. And so do I believe the ones now are like absolute? No,